much. So Linda, thank you so much for helping us to put this thing together and to open this conference.
Well, thank you very much, Vasilis, and good morning to everybody. I want to say I feel a little bit like an imposter because frankly, I know next to nothing about 1,4-dioxane. So I've actually spent some time the last week reading about it and trying to learn something about it, but I'm really looking forward to spending a day just absorbing much of the information. But what I really want to do is just give you a little bit of a history kind of contaminants in drinking water. In the past, I have worked on disinfection byproducts in drinking water. I've certainly worked on some other, for example, contaminants in water. I'll tell you when to turn the slides, but recently I've been focused on excuse me, on PFAS. If we go to the next slide, thank you. Okay, so this is just going back in ancient history. Over 3,500 years ago, Egyptians boiled water or put heated iron in water in order to avoid bacterial illness. In the Bible, it talks about Moses cleaned water with a tree. Hippocrates created the Hippocratic sleeve, which was a filtration device that he devised. And I think many of us are familiar. If you've ever been to places where the Romans lived, there were Roman aqueducts all over parts of Europe and parts of the Near East and so on, some of them which actually still function today to transport clean water. There's kind of not too much that I found between, around the beginning of the Common Era and 1700s. But starting right around 1800, actually, Philly built the first public water system in the United States. Many of us look back and think about medieval times and how charming it was. I don't think we think about the sewage that ran through the street in many places. I think everyone probably in this audience is aware of John Snow and his famous taking the handle off the pump, which ended the Broad Street cholera outbreak in London, was also kind of the initiation of a modern public health approach. And by the 1860s, the US had jumped from the first one in 1799 in Philly to over 400, or approximately 400 water systems in the US. By 1900, there continued to be more and more water systems, but the first federal regulations were implemented in 1914. And the US Public Health Service, which many of you may initially remember was set up in the mid-1800s, set the standards for the bacteriological quality of drinking water. And some of the standards that they set were applied to to interstate transportation of water systems as well. Just 50 to 60 years ago, there were about 19,000 public water systems in the US. And in 1969, there was a survey done by the Public Health Service that identified major deficiencies exist in public drinking water systems. Only 70% at the time met the standards of the time. Next slide, please. So the Safe Drinking Water Act, I think many of you may remember, then it's interesting that President Nixon established the Environmental Protection Agency in 1970. In part, that was a response to not only the air pollution we were seeing, but the burning of the Cuyahoga River near Cleveland. That was 1970, and within 4 years, a Safe Drinking Water Act was established. This was actually signed into legislation by President Ford. It was shortly after President Nixon had left the office. But this was really in part driven by the concern over cancer-causing chemicals in New Orleans and Pittsburgh. There was lots of lead in drinking water systems, exemplified by the situation in Boston. And drinking water often didn't smell good or taste good in many cities and towns. The Safe Drinking Water Act authorizes EPA to establish minimum standards to protect tap water, and these standards are health-based. It requires all owners or operators of public water systems to comply with these standards, and the standards are enforced by the states and EPA. There are also secondary standards, which I'll come to later, and there are some minimum standards that the state programs had to use to protect underground sources of drinking water from injection of fluids, and that's something we might think back of when we think about what's going on with fracking right now. And then in 1996, there were the amendments and standards developments, which required, this was the Safe Drinking Water Amendments, which required detailed risk and cost assessment and did require what they determined the best available peer-reviewed science. Kind of makes me wonder what they thought they were using before. Next slide, please. So I think many of us view clean drinking water as an essential human right. And I can tell you that up until maybe 10 years ago, I felt clean drinking water was going to be the issue of the 21st century. Now I think we all realize it's climate change, which is the existential threat. But of course, that does have an impact on clean drinking water as well. But you have issues related to public drinking water systems versus private well water, which can be regulated. The public systems can be regulated, private wells are not regulated. The sources of different kinds of contaminants, we have natural contaminants that just are present in water, like some of the nitrates or nitrites, metals, microorganisms. And then we have lots of synthetic sources. We have different kinds of contaminants. For example, and I'll come back to mention that pharmaceuticals are a big problem. Industrial chemicals, personal care products, hormones, consumer products, and just a couple of examples. Some of my favorites that are in our drinking water are things like fluoxetine and benzene and phthalates and estrogens, and for example, PFAS. Next slide, please. So there's no test required here, and nobody has to memorize any laundry list. But the EPA drinking water rules are basically broken into three categories. One relates to chemical contaminants, and that involves things like the rule for arsenic or the lead and the copper rule, which I think many of us are more aware of because what happened in Flint. We have issues related to microbial contaminants, and here you have the stage 1 and the stage 2 disinfectant byproducts rule, and I'll come back to that later, and surface treatment rules, also the total coliform rule, and then you have right to know rules related to consumer confidence and public notification. Next slide, please. So what are the national primary drinking water regulations? These refer to our regulated contaminants. If they're disinfection or inorganics, for example, there may be maximum contaminant level goals, which are what you'd like to achieve, and then as for protection. But the maximum contaminant levels take into account, for example, technology and what you can achieve. So for example, in order to disinfect drinking water, the three major, and this is silly, well, it can't really be regulated this way. The other disinfection is ozone, but you have chlorine, chlorine dioxide, and chloramine. And you know, sometimes we hear chlorine is often called one of the most effective public health measures ever. And, but it is associated with an increased risk of, for example, bladder cancer. And sometimes you'll hear people say, oh, but what's a 7% increased risk? Well, you know, with an odds ratio of significant odds ratio of 1.07, when, you know, hundreds of millions of people are drinking chlorinated water, that's quite a lot of potential cases of bladder cancer. Anyway, you also have the disinfection byproducts. Depending whether you use chlorine or chlorine dioxide or chloramine, you may get a different spectrum. But the classes here, you have a bromate and chloride, the haloacetic acids, and then the trihalomethanes. And again, depending upon what's in your source water will impact the distribution of the contaminants you get. Then there are loads of inorganics, and the numbers here are actually coming from EPA's primary drinking water regulations list. There's a very nice chart. And for example, some of the inorganics are things like asbestos, but also arsenic, cadmium, chromium, lead, mercury, nitrogen, nitrates, nitrites, and so on. Then you have microorganisms, and there are at least 8 classes, and some of the ones that I picked out were the coliforms. Cryptosporidium caused a big outbreak of GI disease, for example, in Milwaukee about 20 years ago. That was really, many people are sick. Giardia, viruses, and Legionella would be another one I could have included here. Then there are loads of organics listed, and they fall both into categories as well as individuals. So you've got lots of pesticides, lots of volatile organics, lots of semi-volatile organics, as well as things like PAHs and benzene and so on. And then radionuclides are also regulated. So the alpha and beta photon emitters, but also radium and uranium, which is uranium is a real issue, for example, in out west, just for example, on the Navajo Reservation and some other places. Next slide, please. So then we also have secondary drinking water regulations. EPA calls these nuisance rules, and these are non-enforceable guidelines. But these involve things or based upon, for example, cosmetic or aesthetic effects. I think, for example, fluoride at higher levels is associated, for example, with mottling of teeth. And I don't think your teenagers would consider that a nuisance, for example. So I think there are issues about who defines what's just cosmetic or aesthetic effect. But this is issues like color, odor, pH, how turbid, for example, the water may be, and foaming agents, and several inorganics, including fluoride, which are regulated at a lower concentration, or the guideline is lower than under the primary regulation. Next slide, please. So something that I think many of us have been interested in is the unregulated contaminant monitoring rules. These were to do these 5-year review of contaminants was established under the Safe Drinking Water Amendments in 1996. So every 5 years, EPA reviews the list of contaminants based upon a list that they draw up called the Contaminant Candidate List. They are currently in UCMR 4, which should be completed this year. And the kinds of contaminants they're measuring are a bunch of cyanotoxins. And I mean, with climate change, algal blooms is becoming a major issue in certain parts of our country. There are 2 metals present. There are a bunch of pesticides. There are 3 brominated haloacetic acids. Under the primary drinking water regulation, you're dealing with chlorinated haloacetic acids. There are 3 alcohols and there are 3 SVOCs. Next slide, please. So again, what are some of the other additional issues related to unregulated contaminants? Well, I think many of you are aware of the fact that there's increasing use of gray water, especially in areas where we have major drought problems or water is always a problem. And something that I think we'll hear more about is the problem about removing contaminants from gray water. We know that, for example, the PFAS are not well removed by many of the traditional contaminants, and I believe that is one of the issues with 1,4-dioxane. And then, you know, nobody's really talking yet about the huge levels of we can find in water of microplastics, especially in recycled water. And then the effects of climate change, the issues of not having enough water, and then the issue of algal blooms. Next slide, please. So what makes a chemical emerging? And these are the kinds of things that would go on the UCMR. Well, they either have things that have just been recently found. They could be unregulated. We may not know much about them. And then we have to ask some questions like, what is the role of chemical management policy in preventing uses that have led to this contamination? What is the role of traditional and emerging toxicology methods to assess the risk to public health? What happens as, you know, our limits of detection get better and better and better? So we used to say, oh, there's nothing in the drinking water. And
there are 10 quizzes.
And then
you can drop 2. Yeah. So what opens okay?
I'm sorry, someone needs to, I think, mute themselves. You know, the point is as we get to lower and lower levels, things that we didn't know were there turn out to be present. And then there are other research initiatives. And I've mentioned some of the things that I see as extremely concerning, which are the microplastics, pharmaceuticals. I mean, most of the things that we take as drugs end up being eliminated and getting either directly into the water supply or into the municipal waste systems, and most of them are not well filtered out. The whole issue of PFAS and 1,4-dioxane. Next slide, please. So some of the emerging contaminants that have been highlighted, for example, like trichloropropane, which is a very, very potent rodent carcinogen. 1,4-dioxane is here. We've got a couple of our explosive agents like TNT and DNT and RDX. We've got lots of nanomaterials, and I think we need to start thinking about them as well. Perchlorate is especially, for example, that's from jet fuel, and we've got huge problems with that, for example, in Southern California. I just listed two of the PFAS here, the legacy ones, which are not supposed to be intentionally produced in this country anymore. We've got the PBBs, we've got the brominated flame retardants like PBDEs, and we've got the metal tungsten. Next slide, please. So what's the problem with dioxane? And I don't know if I was supposed to set us up or not, but I am a little bit. This is a synthetic industrial chemical, high production volume chemical, which is completely miscible in water. I think one of the concerns is that at elevated in temperatures and pressures, it can explode, especially if there's some air around, and I think that's a concern. It is likely at many sites which are already contaminated with things like we know about, like 1,1,1-trichloroethane or other solvents, because its historical use has been as a stabilizer and a paint stripper and greases and waxes. It does have a very short half-life in air, but in soil and in water, it has a very long half-life where it can migrate rapidly from the soil to the groundwater and is resistant to biodegradation. Although I should mention, and maybe we'll hear about it, that there are some microbial degradation pathways or bugs that are being developed. It has been declared by EPA to be likely carcinogenic, by EPA is likely carcinogenic, and by the National Toxicology Program in its reported carcinogens to be a likely carcinogen to humans by all routes of exposure. Acute exposure is associated, it's an irritant, eye, nose, and throat irritation, and long-term exposure is associated with kidney and liver damage and eventually carcinogenesis. Next slide, please. So just again, nobody has to mention any of this, but I think the important thing to point out, these are guidelines. There are no regulations that I know of, but guidelines in a number of states. And what you can see is there's a tremendous variation in the level of the guidelines. So Alaska has a guideline of 77 parts per billion, parts per billion. But then you go down to say Colorado is 0.35 parts per billion, kind of similar to Massachusetts and New Jersey and so on. So again, it's and thank you for someone putting in the chat that Michigan now does have a level, which is pretty low. Well, it's not as low as I'd like to see it. Next slide, please. So what are the big problems with 1,4-dioxane? Well, I kind of alluded to it before. It's very difficult to remove from the water. Standard treatments or things like granular activated charcoal don't do a good job of removing it. So it's hard to get rid of it, and you require special treatment processes such as advanced oxidation. Next slide, please. So with that, I'll say thank you. I hope I've set this up well, and I'm very excited to spend the day listening and learning from the rest of you. Thanks a lot.
Joining us.
All right, thanks so much, Vasiliou. And it's such an honor to have followed Dr. Birnbaum and to have heard her wonderful overview of 1,4-dioxane. I myself learned quite a bit from hearing her presentation. Today, I'll be walking you through the evaluation that the IARC Monographs program has done for 1,4-dioxane. And I must admit up front, this is very old news, but it does, I think, help to elucidate some of the early findings that led to the determination of the
Mary, you're muted.
Thank you so much. I don't know how that happened. I was unmuted before and now I'm muted. Did you hear anything of my presentation so far? No. All right, let's go back. And I keep getting muted somehow. The host is muting everyone and then that mutes me. Okay, so I am now unmuted and you should be able to hear me. I'll be giving you an overview of the previous evaluation of 1,4-dioxane by the IARC Monographs program. And I should say this is a bit of old news. We haven't had a recent evaluation of the chemical, but it does give you some insight as to the early information that was available at the time that the monograph was done about 12 years ago. IARC First, to give you an overview of who we are and what we're all about. We are an organization, an international health organization that generates data from multidisciplinary research that is generally conducted across continents. That's one of the things that really sets us apart from some of the other organizations that do cancer research. But in addition to the research aims, we also evaluate data through independent expert review. And I'm sure many of you are familiar with the WHO Classification of Tumors series, the so-called Blue Books. That operates out of the IARC here in Lyon. There's also been a resurgence of the IARC handbooks of cancer prevention in recent years. We have various IARC working group reports, as well as produced global cancer statistics through linkages to cancer registries worldwide. But what I'll be talking about and what's near and dear to my heart is the IARC Monographs, which for nearly the last 50 years has evaluated the carcinogenicity of a wide range of agents. So to give you an overview of what I'll talk about today, I'll walk you first through the process of IARC Monographs evaluations. Then I'll give a summary of the evidence synthesis that took place for 1,4-dioxane, and lastly conclude with data gaps for human carcinogenicity evaluations. So the Monographs evaluates any type of agent in its program. We started out evaluating chemicals, and that was our bread and butter for the first maybe 30 years, 20 to 30 years of the program. But then it was extended to include physical agents like ionizing radiation and non-ionizing radiation and solar radiation for that matter, as well as complex mixtures such as tobacco and most recently opium consumption, which is very recently declared to be carcinogenic to humans. Also complex mixtures like air pollution and occupations, including work as a painter and work as a firefighter. We also evaluate various biological agents, including many viral agents that are known to be carcinogenic, pharmaceuticals, and then of course components of diet, with processed meat and alcohol consumption being of great interest. Of course, what we do in the monographs is convert the huge amount of literature that's been developed around carcinogenicity into the iconic orange-hued volumes that I'm sure you're all very familiar with. And it's quite a process to get there, which is dictated entirely by the preamble to the IARC monographs. This is the set of procedures that guides participant selection, management of conflicts of interest, discussion of stakeholder involvement, and how we actually conduct the meetings themselves. It describes the separate criteria that are used for the review of the human and the animal carcinogenicity evidence, as well as mechanistic evidence, which is increasing in importance in recent years. And then finally, it describes the decision process for reaching the overall evaluations. This preamble was recently amended, and a new version amended about 2 years ago is now available on our website. Well, 3 streams of evidence are brought together for an overall evaluation, as I've already mentioned. But in addition, a very important aspect of each monograph is to summarize pertinent exposure information. The evaluation itself is a systematic review that consists of 5 steps. Step 1, identifying relevant information, and step 2, screening, selecting, and organizing the studies, are done largely by the Secretariat here in Lyon. We bring together independent experts to serve in our working groups, and it is they who evaluate study quality, report on the study characteristics, and then step 5, synthesizing evidence to reach an overall evaluation. These evidence streams, as I mentioned, consist of the 3, cancer in humans, cancer in experimental animals, and mechanistic evidence. The categories for each of these I'll describe in a little more detail. Just wanted you to note here that for cancer in humans and cancer in experimental animals, the categories are exactly the same, but of course the criteria are quite different to reach those different levels. Mechanistic evidence, importantly, can be based on 3 different aspects of mechanisms. One is mechanistic class, that is whether the agent belongs to a class that behave in certain ways, not just chemically, but also toxicologically. So a good example of a mechanistic class could be aromatic amines, to which we've just added aniline in addition to orthotoluidine and several others. In addition, there's a review of what are called the key characteristics of carcinogens, and I'll elucidate those shortly for you. The last determination is mechanism that is observed in animals and in the bioassays is deemed not to be relevant to humans. So that could present strong evidence as well. The two other categories, limited and inadequate, are similar to those used in the other two evidence streams. Then, as I said, these are brought together to reach an overall evaluation. And here, the numbers that you see in each group indicate the number of agents that are in those groups. So group 1 is carcinogenic to humans. We have 121 agents there. Group 2A, probably carcinogenic to humans, 88 agents in that category. Group 2B, possibly carcinogenic, we have 313. And the largest group, group 3, not classifiable as to carcinogenicity, is almost 500 agents. I had mentioned just now the 10 key characteristics of human carcinogens. And this is a very active area of research, which our senior toxicologist, Kate Guyton, has really been a global leader in. And I would really like to stress that this concept evolved out of the volume 100 monograph series, which took place from a set of meetings that occurred 11 years ago, and resulted in some workshops that brought together what we know about all the known human carcinogens and what their mechanisms are. So there are 10 here. I won't go through them all, but as Kate likes to say, this is a top 10 list of behaviors of carcinogens. I think that's a good way to think about it. These are the chemical and biological properties of established human carcinogens, and they can be used in subsequent evaluations to provide evidence of carcinogenicity, even if we don't have it directly from either animals or humans. They're used to assemble the data that are relevant to mechanisms without having to have any a priori hypothesis about the mechanism that might be in place for any given agent. So it brings a sense of objectivity to the literature search and to the data assembly. So now just to touch briefly on how the evidence is evaluated. For cancer in humans, as I mentioned, there are 4 categories. This last one, ESLC, is evidence suggesting lack of carcinogenicity. So for sufficient evidence, a working group determines that a causal relationship has been established and that chance, bias, and confounding can be ruled out with reasonable confidence. For a determination of limited evidence, the working group determines a causal interpretation is credible. However, chance, bias, and/or confounding could not be ruled out with reasonable confidence. And you see there that there's plenty of room for expert judgment to determine which category an agent may fit. A third category, inadequate, often arises when no data are available, or there are few data, or they don't show a positive association overall. Evidence suggesting lack of carcinogenicity. This is when high quality studies covering a full range of exposure are consistent in not showing a positive association at any level of exposure. And a good example there was for the coffee monograph. There were several sites that actually have inverse associations with coffee consumption. And here a determination of ESLC was made. For animal bioassays, the conclusions are a little bit more straightforward. For sufficient evidence, here we must have multiple positive results, at least 2 positive results in 2 different species, 2 different studies, or in both sexes of a good laboratory practices study. Exceptionally, a single unusual result in terms of tumor multiplicity, incidence, site, or type, or the age of the animals may lead to a determination of sufficient evidence. For limited evidence, there's again a suggestion of a carcinogenic effect, but we don't quite have the level of evidence needed to reach a sufficient conclusion. And inadequate evidence means studies permit no conclusion about the presence or absence of a carcinogenic effect. ESLC, I'm not sure has ever been used to reach a conclusion in the animal bioassays, because usually we don't have enough studies that are well conducted to actually reach such a conclusion. The mechanistic evidence is, as I said, evaluated a little bit differently. For a determination of strong evidence, the determination is that the results in different systems are consistent and that the overall database is coherent. It's required that studies cover a range of relevant endpoints, including in mammalian species. And the determinations for limited and inadequate are much reduced from there. Now I'll turn to how the overall classifications are reached. And these are on the basis of our amended preamble. As has been the case for the entire duration of the monographs, Group 1 is usually based on having sufficient evidence of carcinogenicity in humans. However, it may also be based explicitly now on sufficient evidence in bioassays plus strong mechanistic evidence in exposed humans. And this would be strong evidence of the key characteristics of carcinogens. Notably, group 2B is based on having only one stream of evidence in effect, and it's not sufficient in humans. So there could be limited evidence of cancer in humans, sufficient evidence in bioassays, and or strong evidence in experimental systems, but not a combination of those two things. That would lead to a group 2B designation. By contrast, group 2A is based on two streams of evidence, at least one of which is in humans, and it's limited, or human cells or tissues. So here you can see the various combinations that could lead to a determination of group 2A probably carcinogenic. One exception is if there's strong mechanistic class evidence. That is all that is required to reach a group 2A evaluation. Now, with that background, I'll summarize the evidence synthesis that took place for 1,4-dioxane. And as I mentioned, this happened about 12 years ago in Monograph, or I'm sorry, many more than 12 years ago, 1998. That is 22 years ago. So it was quite a long time ago now. And it was published in Monograph Volume 71. The exposure database for this monograph was very, very slim. Here you can see what was typically produced, which is just structural and molecular formulae and basic information about the chemical. This is all we had at the time about production and use of 1,4-dioxane. It was it was not quite a high production volume chemical back then, but I think as Linda said now, that has changed. Its use as a solvent is well noted here. And I'm struck by the very broad number of consumer products in which 1,4-dioxane existed. But what was notable about this section is that there were no occupational data available to the working group. And the only mention of environmental exposure or occurrence was that 1,4-dioxane had been detected in ambient air samples. So there was no mention then about drinking water exposure levels or concentrations. The human cancer evidence was determined to be inadequate, as you'll see, and that's because there was really only, there's hardly any data. There was a very, very small prospective mortality study of 165 workers at a chemical plant in Texas who had been exposed to low concentrations for short durations and were followed between 1954 and 1975. So only 2 deaths were observed from cancer, whereas 0.9 deaths were expected. The bioassay evidence was more robust. Here we see that there were tests in 3 different species tested by oral administration, and in mice, increased incidences were observed of hepatocellular adenomas and carcinomas. In rats, we saw increased incidence of peritoneal mesotheliomas, as well as tumors of nasal cavity, not navel cavity, liver, subcutaneous tissue, and mammary gland. And in guinea pigs, increased incidence of tumors of liver and gallbladder were observed. Inhalation exposure in rats produced no increased incidence of tumors. However, in a 2-stage liver foci assay, 1,4-dioxane showed promoting activity. The mechanistic evidence was evaluated a little differently back then. There's always a section on what we call ADME, which is absorption, distribution, metabolism, and excretion. And 1,4-dioxane was determined to be rapidly absorbed upon inhalation or after oral administration. However, dermal studies showed that skin penetration is poor. The major metabolite is beta-hydroxyethoxyacetic acid, which is rapidly excreted. And most mechanistic endpoints that were evaluated were negative. It was negative in most of the gene tox tests that were done. However, it was positive in the cell transformation assay, with conflicting results observed in mouse bone marrow tests for micronucleus induction. So I would say it's fair to assume that most of the emphasis in those days from mechanisms was on genotoxicity. This leads to the evaluation. There was inadequate evidence in humans, sufficient evidence in experimental animals. We had that signal of positive tumor findings in more than one species in different studies, and an overall evaluation was that dioxane was possibly carcinogenic to humans, group 2B. You note that there was no mechanistic upgrade here. That was the terminology of the time. So the working group concluded that that evidence was not strong enough to warrant such an upgrade. I'll close then with a very brief summary of some of the data gaps for the human carcinogenicity evaluation. Obviously, with 22 years having gone by, there is room for quite a lot of research to have evolved since then. And a very brief overview would tell us that, that certainly the Monographs program has increased our emphasis on these mechanistic endpoints. And if we were to do a more exhaustive search for all 10 key characteristics of carcinogens, it's very likely that we'd find quite a lot more data, including beyond potentially genotoxicity. A very quick search that we have done for 1,4-dioxane for human cancer studies using our standardized search terms has revealed no new human cancer studies since the 1978 study. However, of course, as Dr. Birnbaum mentioned, the US NTP report on carcinogens in 2009 produced somewhat similar findings to the Monographs evaluation, stating that it is reasonably anticipated to be a human carcinogen based on these animal bioassays. We also go through a process of identifying priorities for the Monographs program. And a year and a half ago, we held a meeting with an advisory group here in Lyon, and they sifted through more than 170 nominated agents that members of the research community and the public had nominated for Monographs evaluations during the period 2020 to 2024. I have here a very succinct summary of them. The working group assigned a priority to about 120 of these more than 170 agents, and they assigned them into high, medium, and low priority. So this list here is the high priority agents, and they're separated by agents that have never been previously evaluated by the Monographs and those that have been previously evaluated. And then interestingly, we've indicated what the rationale is for these, and you can clearly see that the mechanistic evidence is often appearing as part of the rationale for either a new evaluation or for a reevaluation, in which it could be that the classification could change. So we actually are in a monograph meeting right now. We've converted our process to adapt to the COVID-19 era, and monograph meeting 128 is occurring as we speak. So we're evaluating arecoline, acrolein, and crotonaldehyde in this monograph meeting. But I would say that no one nominated 1,4-dioxane a year and a half ago for reevaluation by the IARC Monographs, and so it doesn't appear on our priority list. However, if you wish to nominate it, at any time, the members of the public and the research community are free and more than welcome to nominate new agents. I'll provide these slides to Vasiliou after this meeting in case you'd like to look at them, and you can certainly follow this link to nominate new agents. We do ask that you tell us your affiliation and whether you have any potential conflicts of interest, but we also would like to know a bit about the scientific underpinnings of your request. So with that, I'd love to acknowledge the team. We've got a wonderful team here in Lyon, and also the fantastic support that we've had since 1982 from the NCI in the US, since 1986 from the European Commission, in particular, the Employment, Social Affairs and Inclusion DG, Director General, and then the US National Institute of Environmental Health Sciences has supported us since 1992. So I realize that was a bit of a whirlwind through the Monographs and 1,4-dioxane, but I would be happy to see if you have any questions or comments.
All right, thank you so much for inviting me, and it's always great to collaborate with you, Vasilis, and our department on all things 1,4-dioxane. And I'll talk about our MCL setting process specifically with respect to 1,4-dioxane. And I'll just say as backdrop, since I moved over to New York State, I've been very heavily engaged with and impressed by all the focus and advocacy and regulatory cooperation with water supplies on trying to make progress on emerging contaminants. It's not an easy thing for one state at a time to do. New York State has adopted a legislation in 2017 that established the Drinking Water Quality Council and a mandate for the health department to make progress with drinking water and emerging contaminants. And I'll talk a little bit more about that process but it is set up to address not only 1,4-dioxane and perfluorinated compounds, but whatever else is on the horizon in terms of what's being found either at waste sites, remediation sites, what's being found nationally, locally in the UCMR, as Dr. Birnbaum talked about. And by the way, Linda, thanks. That was a great setup to my talk. We're very closely looking at, and the UCMR program is very helpful to the states in identifying what may be coming towards us in terms of public water supplies and contaminants that we may need to set standards for, at least do more monitoring of. So with that backdrop, if you can advance. So again, what are emerging contaminants? This is just level setting. I have on this slide PFOA and PFOS as well, because sometimes I use this slide for multi-purposes, but at the same time that we regulated 1,4-dioxane, we're also, while we're getting approvals, while we're going through the machinations with our Drinking Water Quality Council, so instead of like buy one, get one free, it's sort of like buy two, get one free. We did 3 at once. As far as, our first run through this framework and mechanism for setting MCLs. And it doesn't mean that we've never set an MCL in the past, but this is, sort of the more modern approach to it, and, using the new regulation. What I'll say about 1,4-dioxane is that most of the groundwater, drinking water problems we've seen emerge with it has been because of its use as a solvent stabilizer for 1,1,1-trichloroethane, which was used quite heavily as a degreasing solvent in a wide range of applications. Metal shops, industrial manufacturing, and so these large, uses, drums, vats of these kinds of chlorinated solvents, especially when. Yeah, all right. So one of the points I want to make about, we've already heard about what a maximum contaminant level is, but the key points here of why they are so important, as opposed to, say, just setting a groundwater remediation standard, which we know a lot of states have, or some states have, and are using that as guidance to evaluate when they do get data for a public water supply or for a private well. But when you actually have an MCL that regulates the public water supplies, then that requires testing, and not just one-time testing of the public water supplies, but ongoing, over time, regularly, quarterly monitoring, depending upon the frequency the water supply is under, to test. So they're enforceable, and again, requires the testing. So we really know where the 1,4-dioxane is occurring, and where it's above an MCL, where it may bear for more close watching if it's close to an MCL, and really sets us up to be able to enact, protect public health and enact proactive measures. So, next slide. We like to talk about in New York State, how proactive we're being. We have been the first state in the nation to actually enact a dioxane MCL, and I'll talk more about that in a few minutes. But we realize that there's a big challenge with 1,4-dioxane in public water supplies, because it is recalcitrant in groundwater. It is not easy to filter out with carbon or with, it's basically, you can try reverse osmosis, but your standard treatment methods are not easy to use, and so and all that effective, especially for a large supply. And so what has been developed is what's called advanced oxidation process, or AOP. And meeting that challenge is part of the development of the MCLs to make sure that if we set a standard, that it can be met, and within a reasonable time frame and for reasonable feasibility. And it was needed, again, as I said before, for New York State to act to become the first in the nation to hopefully, not be the only one to have an enforceable MCL for 1,4-dioxane, again, because there's no federal standard, although it was part of the UCMR 3 test round. And so we learned a lot about the need for this in New York State through the EPA test rule and what we saw in our water supplies. Next slide. So the goal of the MCLs are to be far below any known effect levels for 1,4-dioxane. Again, as we just heard from IARC, that data is basically from animals. To protect all life stages, including children and pregnant women. And we're recognizing that, especially in the case of a chronic agent like 1,4-dioxane, that it could take years of exposure to accumulate to a substantial risk. So what we've established is not what we would call an acute standard like nitrate when there's an exceedance of that because of the potential acute effects in children, but this is what we call a tier 2 standard, which drinking water standard, which goes along with many, many of the other chemicals we regulate, like benzene in water. If there's an exceedance there, it's a tier 2 exceedance, not a tier 1 acute exceedance. Next slide. All right, so the Drinking Water Quality Council, it's an expert independent science panel. There were 4 meetings, actually before I think I came to the state, 2017 to 2018, to go over the mandate, the protocols on how the council was going to function, as well as introduction to the leading emerging contaminants that needed the most immediate attention. Again, PFOA, PFOS, 1,4-dioxane. The Drinking Water Quality Council meetings are all public, with public opportunities for public comment. They're all recorded, and there's a dedicated website URL for the Drinking Water Quality Council, which is very easy to find online, that you could see all of the deliberations recorded over the past, since 2017. And we reviewed, the health department reviewed, and I'll go over this review in a little bit more detail because it touches especially on some toxicology, which this audience may be interested in. But we reviewed the occurrence, the toxicology / health risks, treatment feasibility for the council's deliberations. And then in December of 2018, they recommended to the DOH commissioner 10 parts per trillion for PFOA, 10 parts per trillion for PFOS, and 1 part per billion for 1,4-dioxane. And I'll go over the 1,4-dioxane aspect of that next. So if you could advance the slides. All right, so we looked at both non-cancer and cancer endpoints for 1,4-dioxane because in classic risk assessment approaches, there is this thing called the RFD, which has a threshold concept, and looking at here a wide range of effects, not necessarily cancer, but all the non-cancer tox profile for the chemical. And the reference doses that we were able to identify based upon 2-year studies on 1,4-dioxane in rats and mice, focused on liver toxicity effects and the reference doses were 0.1 or 0.03 milligrams per kilogram per day, as you could see, based upon ATSDR and US EPA, slight differences with being an extra threefold database deficiency in 2011 used by EPA for its overall 300-fold uncertainty factor and that reference dose. But when you go forward to the next slide, where would that leave you with a drinking water guideline? Much higher targets for the non-cancer endpoint of 60 to 700 micrograms per liter based upon those reference doses. So that showed us that probably cancer was going to be the driving endpoint and concern in setting the a drinking water standard. So if you can go to the next slide. So here is a range of values, and I'll talk a little bit about what's behind these. I don't have time to go into any of these determinations in detail, but this is what we had in front of us, at least as far as 2018 goes. I haven't updated this slide since then, but what was presented to the Drinking Water Quality Council in terms of the range of determinations at the time. So you can see the New York State number isn't on here because we hadn't derived it yet. But we presented, sort of the de minimis 1 in a million lifetime cancer risk target that is derived from the US EPA iris oral slope factor that's based upon liver tumors in female mice from Kano et al. 2009, which is, a very influential study in this arena because it showed, even though there's, positive liver cancer data in both rats and mice, in both genders, both in rats and mice. So it's very, very consistent liver carcinogen, no doubt about that. But the most sensitive endpoint, as EPA identified in 2018, was this female liver cancer response, which gets you to a de minimis level for standard default drinking water assumptions in adults of 0.35 parts per billion. New Jersey DEP, as of 2015, had reviewed it and developed guidance, again, based upon the same study of an 1 in a million target, cancer risk target, as a as a groundwater remediation target of about the same number. In terms of parts per billion. Minnesota Department of Health, slightly different approach. They had settled on 1 part per billion as guidance, again, for remediation. And Michigan, which had a major 1,4-dioxane contamination issue in the Ann Arbor area, as well as other places in the state, set a remedial program cleanup value of 7.2 parts per billion, which was used to enforce my understanding of it is it was also used to enforce cleanups at public water supplies, but it wasn't an MCL. None of these values I just talked about were in the realm of MCLs because they don't require ongoing testing of public supplies statewide for this contaminant. Other literature we brought forward for the Drinking Water Quality Council were evaluations done by Health Canada and by Darrison et al., which were basically acknowledging that there are cancer effects, consistent cancer effects in animals, but the arguments being that they weren't necessarily linear to low dose, or the confidence at low dose that these effects would be transmitted down to very low dose. They weren't confident with that, and they were doing a margin of an exposure approach, which is sort of more of a threshold type concept, and we're coming up with much higher drinking water targets of 50 to 350 parts per billion. So, we wanted to lay out for the Drinking Water Quality Council these various ways to, connect the dots and make a determination. So, next slide. So what we also presented to the Drinking Water Quality Council is some updated information on mechanism, and there's some really interesting data here, and it's why I'm so happy to be collaborating, or at least being aware of Dr. Vasilou's research endeavors on the P42, on the mechanism of 1,4-dioxane carcinogenicity in rats and mice, and potential for understanding its low dose potency in humans. It's really still an emerging area. I think liver cancer in general is a very interesting mechanistic area. We know that liver cancer is on the rise in humans. There's a variety of reasons for that: fatty liver disease, metabolic disorders, alcohol exposure, type 2 diabetes, and all that backdrop, which is a lot of promotional things and inflammation on the liver, does sort of set the stage for a chemical like 1,4-dioxane to be a special concern. But it's important to again understand that mechanism and how the mechanism may interact with some of these other endemic problems that we're seeing in the U.S. population regarding rising rates of liver cancer. And anyway, the non-genotoxic concept is basically, the argument is that it's a high dose cancer effect that is secondary to proliferative hyperplasia and cytotoxicity. Well, cytotoxicity then leading to proliferative hyperplasia and basically releasing all the growth controls on adult liver and making it more like a neonatal liver, or rapidly allowing for more rapid or partial hepatectomized liver, allowing for that rapid growth and promotion of initiated cells. So is that the entire story? Well, if you look closer at the Kano et al. 2009 tumor results, you see that in the female mice study group that I talked about, that they had 70% liver tumors at 66 milligrams per kilogram per day, which is not a whopping dose of 1,4-dioxane, and they reported no cytotoxicity. 70% versus 10% liver in tumors in the controls. And when you start looking at some of the advances in the mechanistic data that's been published, for example, G et al. Out of Japan, 2018, they did a 16-week exposure in rats in a transgenic liver model. Yeah, I think that's the study. Yeah, a transgenic mouse, a rat model, in which they were able to identify through the transgene mutations, mutational spectra, that by fishing out that gene and changes in that gene that's residing now embedded in all the liver cells, and they found a benchmark dose lower level for or BMDL of 51 milligrams per kilogram per day for those transgene liver mutations caused by 1,4-dioxane. So again, pointing out that in vivo, and that was only 4 months study, you can start picking things up that you don't necessarily see in the in vitro mutagenicity test batteries, which, largely have been negative. So in vivo, we see mouse micronucleus turning up positive, a relatively high dose, I'll admit. But we're also seeing these other signals that there might be more going on in vivo in terms of mutagenicity, or let's just call it genotoxicity endpoints, than the in vitro data may suggest. And so again, liver cancer, all the factors that can cause it from a chemical like 1,4-dioxane, very interesting to explore, and mechanistically, I think, is great material for more research. The only other thing on this slide that I want to emphasize is that the top line, that if you don't know that it's not if you don't know the mechanism, if you can't really prove it, or prove maybe is the wrong word, but if you can't really scientifically, with great robustness and strength, document a nonlinear mechanism, then the default is linear low dose. And that's what, the Drinking Water Quality Council finally settled on, and targeting, 1 part per billion as the standard. And, why not the de minimis 1 in a million, 0.35 or 0.4 target? And, when you're setting an MCL, you're going to learn a lot. And you're going to see a lot of low level, chances are you'll find data on low level detections that you wouldn't otherwise know about. And we don't know the playing field, the background levels that we're going to encounter. 0.35 or 0.4, we know you could find in surface waters from the receiving rivers outside of wastewater treatment plants. So we know that because of consumer products, that 1,4-dioxane is in the environment. It may show up in surface water or groundwater for no other, good reason at these kinds of low trace levels below a part per billion. And so the council felt most comfortable feasibility-wise, technology-wise, with AOP having to come on board, as well as health protection-wise, to set the level at 1 part per billion. And Vasilis, please stop me if I'm over. I do want to just get to.
No, go ahead.
If I
Go ahead.
can.
Go. We have a few minutes. Yeah, we have time.
Okay. So if we can just roll it forward. Okay, so the range that we gave them, or that they really focused in on, was the 0.35 to 7.2 part per billion range in terms of making their determination. Again, based upon linear low dose, and they recommended to my commissioner 1 part per billion, go ahead. So then from December 2018, what happened next? We adopted that recommendation, put together a rulemaking package for the 1,4-dioxane standard, as well as for MCLs for PFOA, PFOS. Draft regulation during 2019 went into the state register, 60-day comment period. On our overall regulatory package, we had 5,000 comments, ballpark, so quite a lot for us to answer. We responded to the comments, did some minor amendments to the reg, including what we're calling a deferral process, which I can discuss if there's questions about. You can certainly find out a lot more about that on our website. Final regs were adopted by our Public Health Planning Council in August 26th of this year. So this is brand new. We're just now, during a pandemic, this is a major new program. And it's not new in terms of regulating drinking water. We do that anyway, but to have 3 new standards that we're requiring all the public supplies to test for, and then to mitigate where there's exceedances and to risk communicate on, it's a huge coordination effort with local health departments and public water supplies. So we're doing that as we speak. And if we could just go to the next slide so I can finish up. Yeah, so not only if there's an exceedance are the supplies required to mitigate as fast as possible, but they're also required within 30 days to notify their customers that there has been found an exceedance of an MCL, and then to keep describing to their customers, either in the annual water quality report or in other kinds of updates, what the compliance timeline is, which that's our job at the health department and with local health departments to hold their feet to the fire. And as I said, advanced oxidation is the way to go here in terms of a large system to treat 1,4-dioxane, which is expensive. And I'll just say that each case is a bit of a research engineering project on its own to make sure that the AOP is done well, doesn't create byproducts, is properly designed and tested before it goes online and everybody starts drinking, the AOP treated water. Okay, why don't we go, finally, the funding part was a big piece here that for these 3 emerging contaminant MCLs, we wanted to make sure that there was funding in place to assist. A lot of public water supplies are run by counties or municipalities. So in particular, to help these local water districts and authorities fund this mandate, the $350 million was made available for emerging contaminants through the Water Infrastructure Improvement Act, and that we are helping to, through a grant process, to fund these AOP projects. So I'll stop there. Thanks so much.